So I'm going to talk about the role of radical prostatectomy or surgery in high risk or locally advanced or oligometastatic prostate cancer. This is something more from my clinical world. Many of you were asking me, do I only do research? No, I actually spend more time in the clinic and operate, and mostly prostate cancer, so that's why I'm going to talk about the role of surgery in advanced prostate cancer. So, this is my disclosures. So I'm going to start with a clinical case that I thought was really interesting, and in the case that the patient eventually had surgery. So this is a 61-year-old man who came to an outside urologist essentially because he needed life insurance and had a PSA test, and his PSA result was 7.76, so he was referred to a urologist, not me, but somebody from an outside institution. He had a PSA of 2.91 a couple of years prior, and his PCA3 was actually 27. Once he saw that urologist, they decided not to do a biopsy. They said, why don't we just recheck your PSA in a couple of months? But unfortunately, as it happens so often, the patient never followed up, got caught up in other things, and eventually, a couple of years later, came back, but now his PSA was 39.7, and rechecked at 36 a couple of weeks later. He then had a prostate biopsy, and now we're in August 2017, and a biopsy showed a couple of cores of Gleason 8. So if we stop the case right here, we have a patient with high-risk prostate cancer, and as you know, there are a couple of options that are available, and this is the latest NCCN guidelines, guidelines that we use a lot in the United States because they're multidisciplinary. There's urologists, radiation oncologists, and medical oncologists on the panel. So the options, as you know, are either radiation therapy with long-term androgen deprivation therapy. There's also radiation with a boost of brachytherapy and androgen deprivation therapy. And finally, us surgeons, there's the option of upfront radical prostatectomy with adjuvant treatment as necessary, depending on the features at surgery. The window of opportunity for local treatment for prostate cancer is an evolving target. The previous presenter, Ashwin and others before that, they alluded to the whole spectrum and where is the role of androgen deprivation therapy, because we know that it works for metastatic prostate cancer, but we are continuously moving it this way where we know that external beam radiation therapy, we're supposed to give long-term androgen deprivation therapy, but maybe there's a role for these novel agents even in the localized setting, as some people are thinking. On the other side, the role of surgery, we know that localized disease, it works, but we are also thinking, well, maybe we can go a little bit further down the spectrum of, for example, oligometastatic prostate cancer and even full-blown distant metastases as well. So a couple of things. So we're going to talk a little bit about the current trends in prostate cancer and why is this question important. I think in the United States especially, this is extremely important because in 2012, the United States Preventive Services Task Force changed the recommendation for PSA screening, which changed again quite recently. But back then in 2012, they decided that PSA screening should not be done for most men in the US. What's really important for you guys to also understand is that the USPSTF recommendations, it's not just the recommendation. It also decides what is being reimbursed. So all the tests that are considered recommended by USPSTF have to be done for free regardless of patient insurance. And that's not the case anymore for PSA screening once this recommendation came out. The other thing is that the USPSTF recommendations have an impact on quality metrics about which hospital is doing their job correctly. So for example, in breast cancer, if your hospital is a participating ACO and you do not meet the criteria for the number of people who are getting breast cancer screening, you will lose money. So the fact that PSA screening did not make the cut, it is no longer a quality metric, and as a result, that will probably influence PSA screening trends, and that's what we showed in this JAMA paper in 2015. Potentially as a result of that, or potentially as a result of other factors, we have seen an increase in metastatic prostate cancer at presentation. This is a paper that was published by my colleague Jim Hu in 2017, and he showed an increase in metastatic prostate cancer at presentation over time. even at the localized stage for different reasons, we also see that the trends are emerging that there's more and more high-risk prostate cancer at presentation. This is work from our group, and we have shown that, for example, in this image, there is more high-risk disease over time, and also a higher proportion of Gleason 8 constitute the high-risk category as we move forward with time. So in terms of treatment trends in the United States, and this is a paper that was published a couple of years ago, what you see here is that there's an increasing role of surgery for high-risk prostate cancer, because initially, as you can see in 2004, there was actually much more radiation therapy, but with time it seems that surgery has picked up. Again, it's not saying that because people do that it's a good thing, but it's interesting to see that surgery is increasingly popular in the high-risk setting. So there's a couple advantages to doing surgery in the high-risk patient, and I think most of you know that. Accurate staging is potentially one of the ones that we, as surgeons, mention to patients in the multidisciplinary setting. A lot of high-risk patients, we think they have aggressive disease, we think it's Gleason 8, but only when we do the surgery do we actually know exactly what's going on. There's one thing that I did cross off, which is the fact that if you do surgery, you can do radiation afterwards, whereas if you do radiation, it's pretty hard to do surgery. I don't like using that as an argument because although a lot of surgeons, at least in my country, tend to use that, the reality is that there's no clear data that really supports the fact that having that extra option makes a difference in the patient's livelihood. I do find that the argument is easy to understand, and if you're trying to sell surgery, a lot of surgeons will sell that, will say that because it's easy for patients to understand, and then they think that by doing surgery it's a better thing. But again, like I said, I don't think that that's a really valid argument, or at least it lacks the evidence to support it. There's also questions about better local control, and local control in the sense that if you're taking the prostate away, the cancer can't grow locally, can't cause, for example, obstruction of the upper urinary tract, and that's also something that I'll show you a little bit of research on that, but a lot of urologists will use as an argument why surgery should be done for high-risk prostate cancer. And then, you know, the obvious things that actually apply not just to high-risk prostate cancer, but also to intermediate-risk prostate cancer, potentially avoid urinary and bowel toxicities of radiation therapy, and also avoid secondary malignancies. For example, I operated a patient recently who had high-risk prostate cancer, but he also had ulcerative colitis, so he's not the good candidate to give radiation therapy, so it was a pretty obvious choice, and even the radiation oncologist told the patient that he should go ahead with surgery. So what's the data on accurate staging, and why would surgery be a good option for high-risk prostate cancer? Well, this is an interesting paper that was published a couple of years ago, and it's for the case of patients that you have Gleason 8 disease, especially low-volume Gleason 8 disease like I showed you in my patient, where potentially it just happens that that one biopsy caught the worst of the disease, and maybe that when you actually take the prostate out, you don't have that bad disease. And this paper seems to support that idea that there's a significant number of men who have Gleason 8 disease at presentation, at biopsy, but once actually surgery is being done, the disease is being downgraded. So for that kind of patient, doing surgery is potentially a valid argument because it's highly unlikely that that patient, for example, would have occult metastatic disease that was not diagnosed at presentation. The other thing that I think is really important, I don't know if many of you use the MSKCC nomograms when you see patients and try to present them what's the risk of, for example, extracapsular extension or seminal vesicle invasion, and what's the survival rate. When you put these numbers in the nomogram, they ask you about T staging. And in the past, when we say T3 disease, we were based on a digital rectal exam, whereas these days, there's so many patients that we consider T3A disease purely based on imaging. And I'm not sure that you can really compare the patient, the 2000 era CT3 that is found on a digital rectal exam to somebody that has a couple of millimeters of disease that may or may not be crossing the capsule based on an MRI. So when I look at the MRI of the patient here, I am not sure that it's reasonable to say that his 5-year progression rate, progression-free survival is only 34%. So again, I think that you have to also consider that when you say locally advanced in the modern era. what's the data on oncological outcomes? And the reality is that there's a lot of confusion here, and we talked about this yesterday, is that there's not much trial data or level 1 evidence to guide our discussion. There is one randomized trial that had explored the question of radical prostatectomy versus radiation therapy in the locally advanced setting. But as you may remember from this trial that was published in this Scandinavian journal, this study was not powered to look at cancer outcomes. There's only a handful of patients, in this case 8 patients, 9%, who died of prostate cancer as part of this trial. The goal of this trial was more to look at the side effect profile, but it's important to point out that there is actually a randomized trial that explored the question. It's just that this is not the trial to inform our discussion. So what happens when you don't have the trials? Well, we resort to this kind of meta-analysis of all the studies that are out there. And as we pointed out yesterday many times, there's a lot of flaws in looking at these kinds of studies to try to understand which treatment is better. And probably one of the most important thing is the selection bias in prostate cancer care, because typically, because us urologists, for the most part, control the flow of patients, the kind of patients that will be tempted to recommend surgery are the younger patients, and if the patient is 75 years old and had 3 heart attacks, I'm probably going to send them to the radiation oncologist. So when you're comparing these things, it's a little bit comparing apples and oranges, and you can do these kinds of meta-analyses, but they will inherently be flawed. But regardless, this is a meta-analysis that had a lot of attention, cited hundreds of times already, was published in European Urology, I think had like 7 letters to the editor, most of them from angry radiation oncologists saying that this is ridiculous, but it showed that there was a benefit for radical prostatectomy in the localized stage. There's a similar study that was published in another journal that tried to look at locally advanced and high-risk prostate cancer. And again, for the most part, they found that there was potentially a benefit for surgery, but again, data that is inherently biased with the problem of selection. We did a study, so actually a couple of the studies that are cited here I was involved in, but we did do a study ourselves using SEER data to look at comparing external beam radiation and surgery in the context of locally advanced disease. The findings on survival are not new because they are actually part of the meta-analysis that I showed earlier, which showed that, again, there's a benefit for surgery, but selection bias and etc. What is interesting of the study, and that was the point of doing this study, is looking at toxicities. And what we did find is that there's significantly more sexual and urinary toxicities in patients who have surgery in the locally advanced setting. And I think for sexual side effect, it's not surprising. But what we did find surprising is that there was significantly more urinary toxicities on the surgery group. A lot of surgeons are concerned that patients with locally advanced disease, because of the risk of the cancer growing up and having hematuria blocking the urinary tracts, recommend surgery. But at least when we look at men who are 65 and above in the Medicare setting, there seems to be actually worse outcomes on the surgery side. Obviously, we did find that there was less gastrointestinal toxicities, and that's in line with all the trials and all the data that we know. And obviously, there was also less of a risk of needing androgen deprivation therapy, because androgen deprivation is inherent to getting external beam radiation in the locally advanced setting. So obviously, there are disadvantages to surgery. We talked about potentially the benefits of surgery, but there's also what constitute the potential risk. There's definitely this risk of surgery. I think all of us know that going to surgery, although radical prostatectomy is a pretty straightforward procedure, especially in the robotic era, there are risks, and once in a while, unfortunately, some patients are going to have a major complication and potentially have some serious long-term issues with that. The other thing is that that these patients have a high risk of needing adjuvant or salvage external beam radiation and androgen deprivation therapy. So you also have to consider that this patient may end up with the side effects of all 3 treatments and potentially live with that for a long time. You are probably aware of these studies, and definitely in the United States, there was a lot of controversy when these papers came out. Just a little word about functional outcomes, and I think this paper is quite interesting. In this paper, they compared different risk categories and the side effect profile. And one thing that I do think is interesting to point out is what you see on the left, which is sexual side effects. So the difference in patients of intermediate or low risk who are going surgery versus external beam radiation, the difference of side effects is pretty important. But in the high-risk category, it seems that those differences are much smaller, and it makes sense, right? Because you know, on the sides of patients who have external beam radiation, they're going to be in androgen deprivation for a long time. So if you are thinking purely sexual side effects, toxicities, or quality of life, there may not be that much of a difference, and it's important to point that out to our patients. So I was talking about the controversial studies, so here they are. This is a study, it's an institutional series and multi-institutional series. And our institution is actually part of this study. So you may see that we have Anthony D'Amico and Paul Nguyen, Mark Pomerantz, who are medical and radiation oncologists from our institution. And so our patients are included in this cohort. And what they found in this study is that among patients with high-risk Gleason 9 and 10 prostate cancer, treatment with external beam radiation and brachytherapy and androgen deprivation therapy was associated with better prostate cancer-specific mortality and longer time to distant metastases compared to external beam and ADT, but also compared to those who were treated with upfront radical prostatectomy. So that's one study. The other study was from Ennis et al., and they did a similar type analysis using one of the national cancer registries that we have, in this case the NCDB, and they compared external beam plus brachytherapy versus external beam versus radical prostatectomy. And they saw that external beam had significantly worse outcomes, but between radical prostatectomy and external beam plus brachy, there was no statistically significant difference. So this is a paper that we published because I would honestly tell you that I would not have done this study if I did not see the Ennis study here. But one of the issues that I found with this particular study is that they took all comers. All patients were diagnosed between 2004 to 2015. And that includes patients that have a follow-up of barely, you know, a handful of months. Some patients in their cohort had a follow-up of 6 months. And how can you really seriously attribute the difference between groups when, you know, the follow-up is so short? So that was one potential issue that I saw with this. The other issue that I saw with this study is that the NCDB only has overall survival. It's a pretty serious flaw in a database that is made to study cancer. So what we thought we would do is, instead of taking all comers of all ages and all comorbidities and patients with different follow-ups, we decided to do a study with only patients who were diagnosed in the early part of the study period. So rather than looking at 2004 to 15, only look at patients who were diagnosed in 2004 to 2009, and also restrict our age category to people who are really young and also really healthy, so that overall survival mimics as close as possible prostate cancer-specific survival. And if you restrict the study to only those criteria, young, healthy patients diagnosed in the early 2000s, there's actually a benefit for surgery compared to external beam plus brachytherapy. The point of this study is not to say that surgery is better, and I'm sure the radiation oncologists, you know, they hate me already and they're already tweeting about it, but the point of this study was to say that if you design a study in a different fashion, you may end up with different results. I firmly believe that our design is better than the other study, but I am not at all saying that, you know, my evidence is definitive. This is level 2 evidence, and it is more to inform and to generate hypotheses, but I think that it was an important contribution to publish this in European Urology when the other paper was published in the JCO, and now everybody knows about that paper, and they're going to say, well, there's 2 papers that show this. What's the evidence supporting surgery? Well, at least this paper we published. So is this real or fake news, you know, if you want to use the terms and the words that our president likes to use. These are all retrospective observational studies. They have selection bias. You know, one is institutional data, the other is registry data. You know, registry data, more patients, more reliable follow-up. Institutional data has better, more variables, more meticulous data collection. In the end, you know, it seems that the evidence can point both ways, and I think that all the things I said earlier about the advantages and the disadvantages of surgery should inform our approach for these patients and personalize the treatment for these patients, because right now we don't have better evidence to guide us about what's the best treatment for high-risk prostate cancer. We practice at Dana-Farber in a multimodal, multidisciplinary setting. What that means is that we sit together between surgeons, radiation oncologists, and medical oncologists. I think what it does more than anything is that we work as a team. So we don't end up in situations where the surgeon comes in and says surgery is 1,000 times better, and then 2 weeks later the patient sees a radiation oncologist who says, no, you should have radiation therapy. I think that, I try to present the evidence in the most objective fashion, and my message is consistent with the radiation oncologist because we work so closely together. The other thing that I would say is, if you look back at that JAMA trial, that's not trial but study, that showed that there was a benefit for external beam and brachytherapy, I think if anything, one interpretation I can have about this is the importance of multimodal therapy for high-risk prostate cancer. I think that as we move forward and we use more the PSMA PET and whatever new imaging modality we will have, we are going to come to the realization that a lot of patients that we think have localized high-risk disease actually already have occult metastases at presentation. And I think that the benefit is that by getting external beam brachytherapy and ADT, they're probably multiplying the treatments at these, either the occult metastases with the ADT or locally advanced disease with external beam and brachytherapy. Whereas with surgery as a single modality, if the patient is lost to follow-up or isn't getting PSA often enough, we may miss the opportunity for salvage treatment, and that's why surgery looks worse, and at least that's my interpretation, potentially. So if we go back to our patient, there's a little catch in this case, is that I eventually the patient had an MRI, so now he's transferred to my care at Dana-Farber, and when I saw him, I decided he should get a prostate MRI, bone scan, and eventually also a PET scan. So the MRI actually showed this 2.1 centimeter PI-RAD5 lesion with extracapsular extension, so it's locally advanced disease, but also multiple and large right pelvic lymph nodes, some of them measuring up to 1.4 centimeter, which suggest regional metastases. We did a bone scan that didn't show anything, but we also had him do an Axman. As Ashwin alluded to earlier, unfortunately, in the United States, we don't have easy access to the PSMA. The PSMA is only available on certain protocols, and for whatever reason, I think this patient was not eligible. So we had him do an Axman scan. And the Axman did light up in the pelvis in the areas of the right external and internal iliac chains without any evidence of distant metastases. So what we have now is different from the previous scenario. We don't have a patient with high-risk prostate cancer, localized prostate cancer anymore. We have a patient who has regional metastases. So if you go back to the NCCN guidelines for this patient, you have the option of androgen deprivation therapy plus or minus abiraterone, or you have the option of adding to this combination external beam radiation therapy. According to the current guidelines, there is no role for surgery in this patient. What's the data to support potentially the use of external beam radiation therapy? And as you can see, it's a recurring theme. We don't have, not until quite recently, a couple weeks ago, any trials to inform that debate. So the prevailing evidence was this paper that was published in JCO a couple of years ago from MD Anderson. And in this study, what they showed is that there was a benefit for adding external beam radiation to ADT in patients who are newly diagnosed with metastatic prostate cancer. The bombshell or the new breaking news is that, and I'm sure you've seen this, is the data coming out of Stampede. What this study shows, I don't need to recap that, actually we just recapped this. Patients were allocated to radiation therapy versus no radiation therapy in addition to the androgen deprivation that they were receiving as part of Stampede. And what's the key point of this analysis and this paper that came out of Lancet Oncology a couple weeks ago is how they define high metastatic or low metastatic burden. So high metastatic burden here is 4 or plus bone metastases with 1 or plus vertebral bodies or pelvis, or visceral metastases, or both. So their main analysis showed that there was no difference between ADT or ADT plus external beam radiation therapy. However, in a priori defined subset analyses, they did find that there was a benefit for adding external beam radiation therapy in patients with a low metastatic burden as defined earlier. Therefore, the conclusion of these authors was to say that radiation therapy should now be a standard of care option for men with newly diagnosed metastatic disease but a low metastatic burden. What about surgery? This is, like I said, it's a recurring theme. We, unfortunately, don't have prospective trials to inform the role of surgery in the context of metastatic disease, which is unfortunate because, as you can see now with the STAMPEDE data, there is actually data to support the use of radiation therapy in select patients. The other problem is that even if today we sit here and say, okay, let's start a trial, as you can imagine, if we start a trial, we're going to use the imaging modalities of today, the staging methodology of today, and potentially down the road, the trial that we start today in 5 years will no longer be valid when the results come out. And that's one of the big problems of prospective trials in the context of prostate cancer because things are moving so fast. So what do we have to inform our conversations? Well, we have the population-based registries, which have subpar data variables and also are inherently have selection bias. And then we have the case series and cohort studies, which also have issues with selection bias. So just a couple of studies to inform that conversation. This is probably the first paper on the surgical side to have shown some sort of benefit for surgery in the context of metastatic disease. This is a study that uses SEER data, and what they found is that patients who had surgery did better than those who had didn't have any local treatment, and actually those who had surgery also did better than those who had external beam radiation therapy, and this is in patients with metastatic disease. Like I said, the problem with SEER data is that you don't have much information. So all the questions that I'm sure you're going to ask me is like, what kind of metastatic burden, where were the metastases, and unfortunately SEER cannot answer any of those questions. Another paper that I was fortunate to be involved in is using the other large cancer registry, which is the National Cancer Database, to explore the same question. And yes, we replicated the findings from SEER, again, with all the problems of selection bias, but we also found that there was a select group of patients that benefited potentially more from surgery than and those who did not. And the reason we were able to do it in this data set is that the NCB, which biggest flaw I told you is the lack of cancer-specific survival. It actually has a lot more data on site of metastases. It has much more refined data on PSA level at presentations, and that's potentially an advantage of that database. And this is a study that was published in European Urology, I believe, 2 years ago. As I told you also, there's also institutional series to inform the debate, and this is the institutional series from Milan, the group of Montorsi. And I think this study, I applaud the authors to have been able to put this together, but it really highlights the problem with institutional series because this is 11 patients spanning 2 decades, and it showed that there was some reasonable cancer-specific and long-term survival, but with no comparison group, and like I said, spanning decades of cases, so it's hard to make much of a conclusion based on this data or the data from the Mayo Clinic or any of the 3 or 4 series that are out there for surgery with patients with metastatic disease. So surprise, what happened in this patient is not that he had surgery up front or that he had external beam radiation therapy with androgen deprivation. He actually enrolled in a clinical trial that we have at Dana-Farber for neoadjuvant androgen deprivation followed by radical prostatectomy. So we have heard of neoadjuvant androgen deprivation therapy before. It's an old concept. It's nothing new. We know that from previous studies and trials that there's a 50% reduction in positive margins, and it reduces the size of the prostate, but that practice has been largely abandoned because there's no impact on biochemical recurrence. Therefore, it's not recommended, and the data, and this is a study that we published actually a couple of months ago, that showed that it's not a practice that a lot of people do, and reasonably so because no guidelines recommend that. But what's different today, and why are we revisiting neoadjuvant deprivation therapy? Because it is actually a trial that's initiated at our center, of which I've actually enrolled a lot of patients, is the idea that there's 2 things. One is that most of these studies on neoadjuvant androgen deprivation therapy were done a long time ago in an era where most of the patients that were treated were on the low to low intermediate risk category. So it's highly unlikely, right, that Gleason 6 prostate cancer may have benefited much from androgen deprivation therapy. So it's a valid question to ask that if you're just limiting the androgen suppression to patients with high-risk disease, potentially there may be a better benefit. The other reason is that, as we know so much, there has been a plethora of many new drugs that have been FDA approved for use in patients with advanced prostate cancer. Apalutamide, enzalutamide, abiraterone, the list goes on. And it's a worthwhile question to ask that, well, there's such a benefit in the newly metastatic, castrate-resistant setting. Well, maybe if we put these drugs in the neoadjuvant setting, we would find a benefit that we never described before. This is not a new concept. It's a concept that we have been testing over the last few years, and we are now in the third iteration of a trial to examine the use of neoadjuvant androgen deprivation therapy prior to surgery. This is a quick, I guess, meta-analysis or a systematic review that I was involved in, where we looked at the different series out there that have tested neoadjuvant androgen deprivation therapy in the modern era. And the conclusion here is, first of all, a 3-year biochemical recurrence-free survival rate of 70%, which compares favorably to all the data we have in this kind of setting previously. What we also found is that there's a number of patients that will have a significant reduction in tumor size down to less than 5 millimeters, and there's actually a couple of patients that will have a complete response, where on androgen deprivation therapy, when we take the prostate out, there's absolutely no disease left. And I think that's a really interesting pathway, because it would be interesting to understand why these patients responded so well, and who knows, maybe down the road we won't need surgery for certain patients anymore. What's also interesting is that those that responded that well, it seems that they did not have any recurrence, but again, short follow-up, because these are trials that were all initiated in the last couple of years. This is the trial that the current patient here enrolled in, and it's a trial where there's different arms of androgen deprivation therapy, and they're receiving some form of abiraterone, potentially apalutamide as well, and ADT for a period of 6 months, and then they follow up with surgery. There's a second randomization after that where patients can continue the same hormonal regimen for another 6 months versus observation, but that randomization happens after surgery. So this is the pathology of this patient. So it's a patient, if you remember the case, he had metastatic disease to the lymph nodes at presentation with extracapsular extension, Gleason 8 disease, and he had a complete response. So we had no residual disease in the prostate, and of all the 16 lymph nodes that I removed, there was absolutely no positive lymph nodes. At last follow-up, and this is a short follow-up because this patient was only operated a couple of months ago, it's promising. His PSA is still undetectable, and his testosterone has gone back to normal. I guess I'm sure you're going to ask, well, what's the next step? Well, the next step is the phase 3, because we have completed accrual for the previous trial, and hopefully we'll have results of that trial in the next few months, actually, at least the short-term follow-up. And we're about to start the phase 3 trial in 2 months. And in this phase 3 trial, we are really testing the big question that we're asking ourselves, which is apalutamide, abiraterone, and leuprolide prior to surgery, followed by radical prostatectomy versus upfront radical prostatectomy, to see which patient has a higher likelihood of recurrence and eventually survival. So closing thoughts, because we talked about how everything is a moving target. The definition of what constitutes oligometastatic disease is also evolving. A patient that you will see in A that we would call has localized disease. If you do a PET PSMA, you may find that he has pretty significant burden of disease. So as we move forward, like I said, in the high-risk category, and this is why I think they found a potential benefit for multimodal therapy in that JAMA article, we come to realize that this patient, you could do all the surgery you want, but they already have metastatic disease. So I do firmly believe that some form of multimodal therapy is the way forward for high-risk prostate cancer patients. And then the question is, what's the sequencing? Should this be done after in select patients who meet certain criteria, or should we do what we are testing right now, which is neoadjuvant androgen deprivation followed by surgery? So closing thoughts. So several standard of care options for high-risk prostate cancer. Importance of tailoring the treatment, because there is no real high-level evidence to inform us that which treatment option is better than the other. The STAMPEDE data seems to suggest that for low Metastatic burden external beam radiation therapy is now a standard of care option. Surgery is not a standard of care option because there's no high-level evidence to support it. And then there's the whole question that the novel molecules, will it lead to neoadjuvant androgen deprivation therapy coming back in vogue or not? We'll see with our phase 3 trial and other trials from other groups. Thank you.